How are you, everyone? My name is Rim, endoscopic spine surgeon. Thank you for the invitation for me, and I'm so sorry that due to flight problem, I was unable to visit in person and are forced to lecture online. Today we are going to take our time to do endoscopic surgery and consider what we should consider physically. It's my special disclose. In the meantime, thought a lot of effort to advance the endoscope. In all cases of spine surgery, endoscope surgery has become possible. There have also been many advances in the high cervical spine region that makes this surgery possible. Endoscope surgery has an opportunity to reduce tubic fusion surgery. As you know, the endoscopic surgical equipment consisted of endoscopy and the instrument and the camera system and irrigation water system, each of which has an important feature. To create a convenient and safe endoscope, we need to think of these structures: the endoscope size, diameter, and the water pressure, durability, and the lens angle, and some instrument based on the physical theory. Only then we can perform this surgery, 4-level decompression for 4-level central stenosis, and 2-level foraminotomy for 2-level foraminal stenosis at the same time. And endoscopic fusion surgery with small skin incision and minimize muscle damage. And 1-level cervical foraminotomy and the 2-level cervical spinal canal decompression with laminectomy. And C1 hemilaminectomy for C1-2 decompression in case of atlateraxial sheath tumor is also possible with endoscopy. Endoscopic HDF is the next surgery we need to do. We can use the instrument for decompression and implantation, like the open HDF. This is a tool I designed. I think this endoscopic is optimized system for all endoscopic operations. First, let's talk about endoscopic size. The endoscope diameter is small at 8 mm, but the working channel is 5.5 mm, which can be used up to 5 mm calcium punch using gold with high thermal conductivity to seal between the body and lens, encourage durability, and prevent fog from forming at lens. The length of endoscopic shaft is 130 mm. Usually, depth skin is less than the length 130 mm. Because no matter how fat a patient is, the depth from skin to lamina no more than 10 cm. The shorter the endoscope length, the better its structural durability. Diameter of endoscope is another important point. The facet in patient with stenosis is hypertrophied, so the laminar space doesn't exceed 10 mm. That's why an endoscope with a small diameter is advantageous. To reduce damage to the facet joint, the smaller the endoscope diameter, the more advantageous. The large diameter of endoscope makes it difficult to land the laminar surface and makes it uncomfortable to move the endoscope during surgery. The distance between the lens and dura is short in small diameter endoscopy. The careful observation of epidural space is possible. Being able to turn the endoscope is the advantage of a uniportal endoscopy. Just turn the endoscope around, the contact matter can look very close and bone work at the contralateral region get easier. Turning the endoscopy, contralateral region looks like ipsilateral area because the working channel and range is located on the edge, not located in the middle. Range angle should also be taken into account. The 10-degree range angle provides the smallest detail than wider angle range in the narrow spinal canal while turning endoscopy during operation. Surgeon can see that right below ligand flavum to no damage of a dura with a 10-degree range angle. The 10-degree range angle endoscope has a good view of the area just below the ipsilateral cliff, so it can do ipsilateral decompression without damaging the facet joint. Endoscopic system is designed to detect a target in the dense building. As many angles as we can see, we can get more information about pathology in the narrow spinal canal. The calcium punch has a 130-degree angle, which allows the operation to be performed while reducing the dural damage when resection of lateral recess, thereby reducing the operation time. An angle of 130 calcium punch maintains the appropriate angle when removing SAP, so surgeon can complete the task safely and quickly. With a strong tooth force, such as jaw or alligator, punch should be able to quickly eliminate the target. Unlike a George Foreman's meticulous jab, the stronger the tooth force, calcium punch can do the fine-grained work, can finish the laminectomy quickly. In a short endoscope, a short punch is used. The shorter the length of the punch, the stronger the tooth force, then longer, sharper punch. The next generation endoscope calcium punch can be turned into the electronic punch, which can conveniently remove tissue. Next, let's learn about radiofrequency. During surgery, RF for hemostasis purposes is essential. The operation